We can now come to the final discussion. Will you be able to stay with us, Konstantin? Yes, yes, of course. Thank you very much. So we see that our potential participants of the discussion are already connected. Maybe we can do some clarifications. So the starting episode with the identified reduction of visual acuity, dramatic visual acuity. So you connected together with vascular catastrophe, right? Vascular catastrophe. Do I have the right understanding? Yes, absolutely. That was vascular catastrophe. This is how we explain it. If it's so, during the follow-up period, so in this patient, she is 50 plus, right? So, but nothing else happened later on. So on the one hand, it's good, but probably we see that ischemic story is quite doubtful here. Plus to that, we know in the differential diagnosis the episodes in pretty young patients where there was one-sided visual acuity loss due to multiple sclerosis or similar situations, then spontaneously visual acuity could resolve, could return without any treatment. We know such cases. So this start, on the one hand, it's quite interesting, speaking about the switch of ischemic problems into glaucoma, but I think we don't have enough evidence-based data for that. Although it's quite curious whether ischemia may lead to glaucoma. What do you think? Your position? Yes, I think you're right. When the patient referred to us, she came already with established diagnosis from neuro-ophthalmologist, and after all examinations, definitely we had particular doubts, especially after the treatment which was prescribed, the course of treatment, her visual acuity actually returned back to the baseline level. So why, for the whole follow-up period for 2 years, we did not have any other similar situations? Because we regularly provided neuroprotective therapy, vascular therapy. We used ceticolin, mexidol, retinolamine, and others. And I think that was the reason why we saw the stabilization. So the patient was followed up also by cardiologists, and there they try to stabilize blood pressure, centralized blood pressure. Maybe it led to the stabilization of the vascular tone, although such transitory angiospastic condition, angiospastic episode looks very interesting. And keeping in mind her medical history, well, could be expected again. It should be repeated, but luckily we don't see it. No more episodes like this. So, yes, that's extremely interesting story. Quite dramatic start and quite optimistic period of follow-up. Although you face some challenges in the pressure control, but nevertheless, you could successfully avoid some emergencies. Yes, you're right. And at the same time, according to the visual field studies, when she referred to us, we actually reported that from the left eye, there was concentric narrowing. So in fact, it was bilateral disorder in the optic nerve, yes. Thank you very much, Konstantin. Professor Rema, now a question to you. You showed us the importance of peak pressure, but that was curious because your patients were getting combination beta blockers plus carboanhydrase inhibitor. And you said the phrase, "we love it all," and we believe that this is 24-hour control, and this is quite confident control. Maybe you refer us to the studies of Anastasius Kostas, because he loves this combination, and he's a big fan of 24-hour control, and actually he published quite a lot about 24-hour control for this combination. But in your own publications, you are writing that if we add on prostaglandins, we can improve the situation. But if we say that with such combination, we have some risks of peak pressure increases, so why not we use prostaglandins more actively? Maybe we should overprescribe prostaglandins. Could you give any comments on that? Thank you.
Yes, very good question, Natalia. Yes, prostaglandin is the first choice for me, but most of the time I get patients referred to me with another kind of treatment. So that's why I present that. That is a paper published by us, and I think 10 years ago, comparing the drugs. And although the fixed combination of dorzolamide and timolol reduce the baseline pressure similar to prostaglandin, when we list the peak pressure by the water drink test, the prostaglandin are much better to cut the peak, to avoid the peak. So drugs that act in steady state situation similarly, but differently to avoid peaks, are better than one that avoid the peak. And prostaglandin is much better than the fixed combination of dorzolamide and timolol.
Then, let me give you another remark. In Russia, well, at least in my practice, we call it DWT. Drinking water test is almost not used, but now you show passionately that, you know what I want to do? I want to have a glass of water now, 1 liter, and to give 1 liter of water to one of the patients. But, well, you always have no glass. There is glass, no water. There is water, no glass. It's always a mismatch. But, for example, if we use this trick, and maybe we do not recommend patients with glaucoma intensive drinking, just tell them, you know what? You shouldn't drink more than 250 milliliters one turn. What do you think? Maybe we should limit the water drinking.
Yeah, that's another good question. As a matter of fact, we did a research showing that 800 ml is enough to have the ceiling effect of the pressure. It's not necessary to drink 1 liter of water. And Danish Meyer from New Zealand showed that 500 ml doesn't elicit peak pressure enough. So the patient should not drink more than 600 or 800 ml in 5 minutes or 10 minutes. He can split even 5 liters during the day, but not in that amount, because even Palmberg did showed some case from Miami showing that the patient that drink the water before and drink a lot of water before the eye examination, surprisingly had high pressure, very high pressure. And based on that, Professor Kawasa from Moorfields, Professor Pradeep from Johns Hopkins, and others, as suggest, because the problem of the water drinking test is, first, take time for some of the busy clinic. Second, is not well paid, at least in the United States. That's what they said, even Sidney Maddox, from former president of the American Glaucoma Society. The Israeli group, the group from Israel, have an idea to ask the patient to drink 800 ml of water just 30 minutes before the eye examination. Also, Professor Anthony Kauzawa from Morpheus had the same suggestion. So with that, the patient measured pressure only once, and he has the 75% chance to detect the peak, because the peak pressure during the water drink test occurs on 75% of the cases from moderate to severe glaucoma in 30 minutes. In early glaucoma, as Professor Quigley showed, and we also showed, the peak pressure occurs early, in 15 minutes. Why that? Because in 15 minutes, the homeostasis of the eye detect the peak pressure and reduce the pressure. When the peak occurs later on, the eye was not able to deal with the high pressure, and the pressure still keep going up. So you should recommend to your patient not drink too much water in 5 minutes or 10 minutes. And if you want to summarize or optimize the test as published by the group of Israel, ask the patient to drink 800 ml of water in 5 minutes, 30 minutes before you measure the pressure. So you are going very likely to have the peak pressure of the day.
Замечательный совет.
Fantastic recommendation and fantastic analysis. All that sounds very interesting and looks, simple and cheap. It's available almost everywhere. So in the clinic with different income and with different tariffs, definitely it increases the value of this test. And I'm extremely happy that you tackled with this topic today. We have another question here. Our audience is asking other questions. You're welcome. Just a second, we wait.
Так, есть у нас связь, да?
We are waiting for the question from the Federal Medical Biological Center. All right. It looks like it doesn't work from them. So, Remo, I have another question to ask. Can we somehow give contraindications for the drinking water test, DWT? Who should not drink 10 minutes before the eye examination? Please, contraindications.
Heart problems, heart failure, kidney problems, and people very old. But the Australian people from University of Sydney were very smart. They recommend, instead of 800 ml of water for everyone, for the people that are not able to drink 800 ml of water in 5 minutes, to drink 10 ml per kilogram of weight. It will not reach the ceiling effect, because the ceiling effect is reproducible, but any pressure between baseline and the ceiling effect is not reproducible. But you are going to have an increase of pressure. And this gives me the opportunity to say that fluctuation is not important, as they said, as usually everybody says. Because imagine the pressure go from 10 to 15, 5 millimeters of mercury fluctuation. 15 is danger for a patient that has a target pressure of 20? No. But suppose now the pressure goes from 30 to 35, peak pressure, 30, 35. That is very dangerous, although the fluctuation is the same, 5 millimeters. So, to summarize, if the patient has not the possibility to drink water for comorbidities, he is very sick. So usually you don't need to do a water drink test in those patients. But mainly if he has heart failure or a problem with the heart, possibility of heart failure, and kidney problems. That's why I avoid to use the water drink test.
Спасибо огромное.
Thank you very much. Now we have a very clear understanding that we will call it Brazilian test. Yes, Brazilian test. Very juicy name. Thank you. Thank you very much. Well, dear colleagues, it was extremely interesting discussion, although it's very late in Russia. It's almost 8 p.m. Well, in Brasilia, hopefully you have different time and different weather. We have almost 0 now. Hopefully you have plus 30. Well, we are so happy to see all of you today, colleagues from Kazakhstan, from Brazil. Many thanks to all the participants. And I hope with that we can finish. We can finish, and we'll be waiting for the new meetings and hopefully see you at our next webinar. Thank you very much. Have a good evening. Have a good day, and goodbye.